vaccine, the effects of the disease are far much worse than taking the vaccine. So I wanted us to highlight one of the common gynecological cancers, that's cancer of the endometrium, stroke the uterine body. My name is Dr. Mukomba from KNH. Yeah, so this basically addresses two main types of cancer. That's cancer of the inner uterine lining, that's the endometrial lining, and cancer of the uterine body or the uterine muscles. It's a fairly common malignancy among the Europeans is the leading malignancy. In our setup, I might not have the exact figures, but we are seeing an increasing rise in endometrial cancers. I think out of every 10 patients we get, you could have like 3 have uterine cancers of one type or the other. Next slide. Yeah, basically that is what we are talking about. That is the uterus. Of course, on the sides are the ovaries, the tubes. So that inner part is the endometrial lining, which develops endometrial cancer. The next one. Like I said, there is an increasing incidence worldwide. It's the 3rd commonest genital malignancy in women in our setup after cancer of the cervix, cancer of the ovary, and now cancer of the uterus. But in the West, it is the commonest gynecological malignancy, and then ovary, and then cervix lower down. So there are 2 main types of endometrial cancer. That's type 1, which is the one that is estrogen dependent, affects a bit of younger women. The outcomes are good if it's caught early. Then there is type 2, which is more common after the age of 50, and it has more severe histological types, and for some reason it tends to be more common in the blacks, or black women for that matter. Yeah, so it's an illustration of where uterine cancer is overall. For all the malignancies in females, you can see breasts at the very top, at about 32, uterine about 6%, but this is mainly from the Western world. For us, cervix will be somewhere very much at the top. Okay, next. So the difficult thing about this is that there is no routine screening like cancer of the ovary or cancer of the breast. There is no routine screening for cancer of the endometrium. But we should have an index of suspicion in women with especially postmenopausal abnormal uterine bleeding. For women in the postmenopausal stage and they are bleeding, we should have it at the back of their minds, it could be cancer of the endometrium, and we screen as appropriate, or we investigate as appropriate. Those who are perimenopausal, abnormal uterine bleeding, and generally women above the age of 40 with unexplained abnormal bleeding should be investigated for cancer of the endometrium. And so what are the risk factors for endometrial cancer? One of the common ones is those who are nulliparous by age of 40. They are noted to have a high risk of getting endometrial cancer. Those who started having their menses very early on, age 13, 14, and then they have a late menopause beyond 55 years of age, they are at a high risk. Those with metabolic syndromes like obesity, those who are diabetic, have a higher risk of developing endometrial cancer. Women who are on estrogen treatment, like those on hormone replacement therapy, those who have chronic anovulation, like in polycystic ovarian syndrome, and those with estrogen producing tumors. For example, you can have ovarian tumors that produce a lot of estrogen. This raises the risk of developing endometrial cancer. Those who are on tamoxifen therapy, tamoxifen is used for treatment of breast cancer. So if it's prolonged, then these women are at a high risk of developing endometrial cancer. Hence, women on tamoxifen should be screened closely or observed closely for the risk of developing endometrial cancer. There's another group, those who have a family history of cancer. There's what we call hereditary polyposis colorectal cancer. These are patients who get or have relatives who have had breast cancer, ovarian cancer, uterine cancer, and cancer in the GIT, that's the stomach, the colon, or the pancreas. So women with colorectal cancer, women with breast cancer should also be screened for cancer of the endometrium. We do see quite a number nowadays. They are treated for example, colorectal cancer. It is cleared, and later they come back with bleeding, abnormal uterine bleeding or vaginal bleeding. Then when we screen, we find actually they have endometrial cancer. Because this is a genetic mutation that gives them, so there's a genetic risk, and it runs down in families. Women who are hypertensive need to be screened more. With advancing age, the risk of uterine cancer increases. Those who have previous pelvic radiation, and this commonly applies to those who have cancer of the cervix, as a result of radiation, they can actually develop cancer of the uterus later. Those who are not physically active, and this is because this brings about obesity, and as we have seen from above, obesity is one of the risk factors. And those with infertility, also they are at an increased risk of developing endometrial cancer. Okay, next. So more on this hereditary or familial condition, it is now becoming more common in our setup. The only challenge, we are not able to do genetic tests, but these are patients, like I said, who are at an increased risk of getting ovarian cancer, breast cancer, and cancer of the gastrointestinal system, stomach, pancreas, and the colon. There are a few protective factors which seem to protect against endometrial cancer. One is the use of oral contraceptive pills seems protective. Those who use progesterone in the postmenopausal age or as hormone replacement, they are protected. Strangely, smoking, which is a risk factor for all other cancers, is protective, but we are not saying people to start smoking so they don't get endometrial cancer. The disadvantage is far worse than any protection one would get. And those who do exercise reduces the risk of any cancer, and for endometrium by about 30%. It's because it reduces obesity. Obesity brings about, the body makes a lot of estrogens, which puts somebody at risk of breast and endometrial cancer. So a good exercise every day is very good. At least a walk of not less than 15 minutes, which is a very short time every day, is quite healthy. So we'd encourage people to walk a bit, take a lift, take a walk instead of taking the lifts. A bit of a walk, maybe from where one stays to the bus stage. It has a lot of benefits, not just reduction of cancer. It will also help in reducing things like hypertension, the risk of developing frank diabetes, and the like. Common causes that will cause bleeding from the uterus. If there is endometrial atrophy, which is the thinning of the inner lining of the uterine lining, especially in postmenopausal women, those who are on estrogen replacement therapy, those who have polyps, these are like fibroids that grow inside the uterine cavity, and those with endometrial cancer. Okay. So in terms of how we classify this endometrial cancer, especially for those who manage these women, like I said, is in two types. Type 1 is what we call the endometrioid adenocarcinoma. This is what 80% of those who develop endometrial cancer will develop the endometrioid type of cancer, which has very good outcomes when we get it early. Then type 2 is the one that comes now as a result of, not as a result of estrogen exposure, and is the other subtypes like I've enumerated: mucinous, papillary serous, clear cell, squamous cell carcinoma, and undifferentiated carcinoma, and mixed carcinoma. These subtypes they are more aggressive, they grow very fast, and they spread very fast beyond the uterus, therefore worse outcomes. How will these patients present? Any abnormal uterine bleeding, or especially in the most postmenopausal period, the risk of having that resulting from CA is very high, so we should be able to screen for that. When the cancer develops, then you can have pelvic pressure if the tumor is growing and putting pressure on the urinary bladder with difficulties in passing urine. It can put pressure on the rectum and opening bowels. These patients come with constipation. Also, we can be able to pick it when doing routine pap smears for cervical cancer, and we get endometrial cells. In advanced stages, you can have a vaginal discharge, which is watery, foul smelling. And also, if it is spread to the other organs, then it is possible it will give symptoms specific to that organ. For example, if it has gone to the lungs with breathing difficulties, if it goes to the spinal cord, then one will have a weakness in one part of the body or a lot of pain. In terms of what investigations do we do? Like I said, anybody with abnormal bleeding, especially above 40, should have endometrial sampling as a mandatory investigation before any management, because this will guide what type of treatment one has to offer. Without this, then sometimes we end up doing surgeries which are suboptimal for the specific type of endometrial cancer. This sampling can be done in various ways. One, by dilatation and curettage, which is available in almost all the hospitals with theaters. You can use office endometrial pipette sampling, which is very easy, and the pickup rate is very good. You can do hysteroscopy. This is those with the laparoscopic facilities. This is the gold standard where this is available, but we know it's only a few hospitals which have facilities for hysteroscopy. The other important investigation is ultrasound, especially transvaginal ultrasound, or even a pelvic ultrasound. It can pick endometrial thickening. If it's more than 5 millimeters, then you sample to find out any possible risk of malignancy. The other investigations are the imaging modalities. For example, you can do an MRI, which is also very good. It can pick out if there is any thickening, if there is any mass, and how far it has gone. Okay. Yeah, This disease, of course, is staged. The staging is surgical, meaning the staging is done when we do the surgeries. But I must emphasize that you need to know what type of endometrial cancer you are dealing with in order to plan for the appropriate treatment. Yeah, so stage 1 is when the tumor is confined to the uterus. Stage 2, it has gone to the uterine cervix. And then stage 3, it has gone beyond the uterus and now is invading the ovaries and the structures around there. And then stage 4 is that when it has gone to the bladder, the rectum, and when it has gone beyond to distant organs. Okay, next. So apart from the staging, like I said, it's done during surgery. You open, take any ascitic fluid, even if there is no ascitic fluid, then you take 100 mils of normal saline, put it into the peritoneal cavity, wash and take for cytology. That helps. If they are malignant cells, then it tells us the disease is advanced and we're able to give the correct treatment. Then after that, we do a survey, check the whole abdominal cavity, the liver, the colon, the spleen, the kidneys, and see if there are any tumor deposits. And then, of course, those samples will be subjected to histological examination. The things that tell us how long the patient is going to survive are the stage of the disease. Of course, the more advanced the disease, the worse the survival. The tumor type, like I said, if it's type 2, serous, clear cell, then the survival is less, the prognosis is worse, and the tumor differentiation or grade. And as this tumor infiltrated into the myometrium or not, that determines, because if it goes beyond the myometrium, that means it can now spread to the rest of the abdominal organs. But if it's confined, then the outcomes are better. More elderly patients, of course, will do poorly. Those with cervical involvement, of course, that tends to have a poorer outcomes. If there's involvement of the ovaries, there's what we call hormone receptor status. If they have estrogen, progesterone receptors, they tend to do better. And if the lymph nodes are involved, then the outcome tends to be worse. If the peritoneal cytology is positive, that means the disease has spread beyond the uterus. They tend to have a worse outcome. So briefly on uterine sarcomas, like I said, what we have discussed is what happens in the endometrial lining, but the uterine muscles can develop into cancer. You have the pure non-epithelial tumors. You can have the endometrial stromal sarcoma, that's the connective tissue in the endometrial lining developing into sarcoma. Then in the uterine body, the muscle, you can have leiomyosarcoma, which is fibroids that convert into malignancies. About 1% of uterine fibroids can convert into cancer. You can have cancer of the smooth muscle of the uterus, and the other forms of any tissue there can develop into a sarcoma. Okay. So also the presentation is the same: abdominal distension, abnormal uterine bleeding, abdominal pain, pressure symptoms if it's very big. And these are the ones that grow to very big masses. And when you examine, you find a large uterine mass that is rubbery in texture. Okay. So that is a staging for sarcomas. I think might not go so much into it, but stage 1 is when it's confined to either the endometrium. Then stage 2 is when it's involving the ovaries and the tubes. Then you have stage 4 involving the bladder and the rectum, and 4B distant metastasis. Yeah. So of course, in terms of broad management, like I said, the dilatation, curettage, hysteroscopy, pipelles. Sometimes a pap smear can accidentally pick this. And like I said, these ones help us to determine what histology, what kind of surgery the patient is going to have. Okay, next. I think we have already tackled that. The next time. Yeah, so definitive treatment of uterine cancer is 1, surgery. For the type 1 endometrioid cancer, and if it's in stage 1A, then total abdominal hysterectomy and bilateral salpingo-oophorectomy is adequate as treatment. For the one that has gone to stage 2, that means involving the cervix, they need radical hysterectomy and pelvic lymph node dissection and paraaortic lymph node dissection. For all the other histological types, especially type 2 cancer of the endometrium and sarcomas, these are patients who should have radical hysterectomy, pelvic lymph node dissection, and paraaortic lymph node dissection. Then most of these patients, except for endometrioid stage 1, they require complementary treatment, that's chemotherapy and radiotherapy. I must emphasize, for most of the cases of endometrial cancer and uterine corpus cancer, surgery alone, hysterectomy alone is hardly enough treatment. So these patients must be given, must be provided with complementary treatment, and that is chemotherapy and then radiotherapy. Otherwise, without that, the tumor tends to recur. Within a 6-month period, you have it almost worse than it was before. Then it becomes very difficult to treat. So that is still the same emphasis, that total abdominal hysterectomy and bilateral salpingo-oophorectomy is not adequate treatment for cancer of the endometrium. These patients do need additional treatment in terms of chemotherapy and radiotherapy as complementary forms of treatment. This way you reduce significantly the risk of tumor recurrence. Of course, for chemotherapy, if it's the endometrial type, we give 6 cycles of chemotherapy, a platinum compound with a taxane, like carboplatin and cisplatin, and then plus paclitaxel or docetaxel. For sarcomas, something called ifosfamide, gemcitabine, doxorubicin. And then these patients are given external beam radiation plus or minus brachytherapy, as the radio-oncologists will assess and determine what is appropriate for their treatment. Yeah, I think that is the end of the presentation. Now we can tackle the questions, concerns, clarifications.
Thank you, Dr. for that session. It was quite informative. Maybe to begin with the questions, I had a question. How long does a lady have to present with the abnormal uterine bleeding before saying that they actually need the endometrial sampling?
Yeah, and abnormal uterine bleeding should be investigated immediately. We should not wait. So long as it's not the usual menstrual bleeding, or in the postmenopausal age, any bleeding, even once, is bad enough, it should be investigated. So one should not wait. So long as the bleeding is not the normal physiological bleeding, it should be investigated. Uh, Exercise helps to prevent cancer in the form that it prevents things like obesity. So the body doesn't deposit a lot of fat within the fat tissue. And whatever fat is there is burned. Fat is converted. The lipids in the body are converted into steroid hormones most of the time, things like estrogen, testosterone, etc. And some of these hormones do stimulate the cells to convert into cancer if the exposure is for a long time. That's how exercise helps. Of course, indirectly, you exercise, you are less obese, you have less risk of developing diabetes, less risk of developing cardiac or heart problems. In terms of cancer, that's how it works. It reduces the quantity of hormones in the body, especially the steroid hormones, estrogen specifically.
Somebody is asking, how can one differentiate abnormal bleeding caused by hormonal imbalance and bleeding? How can one differentiate abnormal bleeding caused by hormonal imbalance and bleeding due to endometrial cancer? And I think you mentioned that any abnormal bleeding you should do the biopsy. So naturally,
Yeah. For those who are above 40, any abnormal bleeding should be investigated.
That's how
Yeah.
you differentiate the two.
Yeah. For the younger age groups, one will do hormone levels, and one can be able to pick that out.
Another person is asking, uh, hi, can staging be done through laparoscopy? I don't know if they're confusing with hysteroscopy.
It can be done with laparoscopy
Oh.
for setups like in the West where the laparoscopy facilities are readily available. Actually, even the surgeries are done laparoscopically, especially if it's in early stage disease. So it can be done.
Okay, thank you. Is it advisable for women with varicose veins to use oral contraceptive pills? It's probably unrelated, but
Yeah. Varicose veins, they increase the risk of having venous thrombosis. That's formation of clots in the blood vessels. That's why the estrogen containing combined pills are relatively contraindicated. Not absolute, but they are not the best to use.
okay. Another one is asking, what is the current prevalence in our setting?
Yeah, I might not have the specific figures, but it will fall like number 3 among the gynecological cancers. Yeah. So it's rising.
It's rising.
Yeah.
And I had a question. You mentioned that people with breast and other type of cancers, they normally have endometrial cancer. Is it as a primary or is it as mets?
They might not have endometrial cancer, but they are at risk of developing ovarian or endometrial cancer as a risk factor because both 4 conditions, that's breast, ovary, uterus, and the gastrointestinal system, are at risk for those who have that gene mutation that leads to the condition we call hereditary non-polyposis colorectal cancer or the Lynch syndrome, such that someone with a cancer of one part should be screened for cancer in the other part of the body. Like we have so many patients in the world with endometrial cancer and breast cancer at the same time.
Okay. It's interesting how oral contraceptive is bad for breast but good for endometrial. And somebody is asking, explain how smoking can be used in the management of cancer of the uterus. Okay, I think maybe they just need clarification of your disclaimer.
It can't be used.
Yes. It categorically no, as much as research has shown that I'm sure when people are doing that research, they were thinking it makes it worse, and then they found out it's better on people who have it.
Yes.
How frequent does one need to be followed up screening for individuals with risk such as HNPCC? I don't know if that's your scope, but maybe you can answer.
Yeah, we don't have facilities in the country to screen for that. The only people who are justified to be screened are those with first-degree relatives who have had colon cancer, rectal cancer, ovarian cancer, or breast cancer. Then the siblings, for example, if your mother had this condition, or the father had colorectal cancer, or the sister has breast cancer, then the rest of the family should be screened for this genetic abnormality.
Okay. Someone is saying, please elaborate on the role of hypertension on endometrial cancer.
Yeah, it's been shown those who are diabetic and hypertensive, they tend to develop uterine cancer. It's because there are a lot of other inflammatory chemicals involved in those with hypertension, which give the same risk with endometrial cancer.
Somebody in that regard, somebody is also asking, how is diabetes a factor?
Yes, it is, because with diabetes, the body is not able to synthesize the chemicals in the body, and these people tend to have a lot of steroid hormones. Steroid hormones, some are converted into estrogen, which is a direct risk factor for cancer of the uterus.
Okay. Someone is asking, if you have been diagnosed through pap smear that you have a low-grade squamous epithelial cell, what should be the immediate intervention that one should take, and how often should one redo the pap smear, considering that the cells can clear on their own?
Yeah, this is a result given for those who go for pap smears, which is screening for cervical cancer. So those with the low-grade intraepithelial neoplasia, in most of them, the condition regresses or dissolves on its own. But these are patients who should have a repeat pap smear within 6 months. But we also offer, if it's persistent, we offer them colposcopy, where we take a tissue specimen from the cervix for histological analysis.
Mm-hmm. So someone is saying, thank you, Dr. Mukomba, for such informative section. For postmenopausal women who had been on tamoxifen therapy, what are the first aspects to consider before administering doses such as anastrozole?
Yeah, because it's, like I said, tamoxifen is a risk factor because it tends to mimic estrogen. So those with other malignancies that require this drug, we should be able to evaluate the other organs that are risk factor, like the ovaries and the endometrium, and counsel these patients. If they notice any abnormal bleeding, they should be able to report back, and it should be investigated as appropriate.
In stage 3, is there a place for neoadjuvant therapy prior to definitive therapy?
Sorry, I missed that.
In stage 3 and 4, is there a place for neoadjuvant therapy prior to definitive surgery?
Yes, neoadjuvant chemotherapy is where we give chemotherapy drugs before surgery. In those with advanced, especially stage 4, there's a role for giving 3 cycles of chemotherapy so that you shrink the tumor and make it operable. Yeah, so there's a role for neoadjuvant chemotherapy, yes.
Also, is copper implants a risk factor for uterine cancer?
No.
Any known serum markers of endometrial uterine cancer?
Yeah, there is no specific tumor marker for endometrial cancer. Yeah, but we use, for endometrioid type, we can use CA125, but it's not a very good tumor marker for cancer of the endometrium.
So when it's high and maybe you're suspecting ovarian and you ruled it out, you should have a high index of suspicion of
Yes.
endometrium. Okay.
Okay.
Can trauma at an early age lead to uterine or cervical cancer later in life? Someone is asking that. That's a very interesting.
Trauma.
Like rape. If somebody was raped,
No.
probably when they were young. Has anybody?
Unless if one gets infected with HPV or HIV, then that increases the risk.
For cervical as opposed to uterine?
Yeah, for cervical, yes.
Yeah. Thank you for your presentation. In countries where genetic screen is done, is prophylactic total abdominal hysterectomy and bilateral offered?
Yes. In the Western countries, if the risk factor is high, these are the people who go for bilateral mastectomies. They can go for hysterectomy and even oophorectomy as a prophylactic treatment. Then they have more frequent colonoscopies and endoscopies, so that if there's any GIT malignancy is caught. Yes, you can offer prophylaxis.
Oh, okay.
Yeah.
But I noticed you also mentioned in the treatment, you have to follow it up with chemo and radiotherapy. You
Yes.
cannot, in prophylaxis, is there a role there, or you just do prophylaxis, surgery, and you do regular screening, that's it?
No, because prophylaxis means you are removing those organs before they develop cancer.
Oh, so
So
it's
you will not give these things.
Oh, okay. Thank you.
Yeah.
Which is the most effective method of screening? As much as you say there's no way of screening, but you mentioned CA-125.
Yeah, there's no reliable screening for endometrial cancer. What one can do is to pick out those with abnormal bleeding, then they go for ultrasounds and endometrial biopsy. But there's no like annual screening for endometrial cancer.
Is there a role for palliative surgical debulking in advanced stages?
Yeah, sometimes if, for example, there's intestinal obstruction, one can do surgery and put colostomies to relieve the obstruction and enable the patient to be able to eat and survive a little longer. So there's always a role for palliative care. It might not be surgery, it might be surgery, chemotherapy, as well as for pain relief. Yes.
Considering the increase of endometrial cancer in Kenya, does it mean that we should routinely take cervical biopsies for every patient undergoing EUA biopsy for CA cervix?
Ideally, yes. Yes.
Is there a correlation between uterine cancer and hormonal contraceptives?
Like we said, the hormonal contraceptives are actually protective. Because what happens, some of these reduce the frequency of menstrual bleeding. Therefore, there is less irritation on the uterus and therefore reduced risk of endometrial cancer.
Please clarify what's the treatment for stage 1B endometrial cancer?
1B, yeah, it will be total abdominal hysterectomy, bilateral salpingoforectomy, and then plus chemotherapy.
Is there any viral infection linked to endometrial cancer development, worsening prognosis, etc.?
No. Yeah, the virus is for C. cervix, C. vulva. Yeah.
Someone seemed to like PCOS here. So is it advisable for a woman with polycystic ovarian syndrome to use oral contraceptives? If no, which is the best method to use?
They can actually use, they can use oral contraceptives and they actually benefit for them.
So in an nulliparous woman, if they have a recurrent black vaginal discharge, what does it normally mean?
One will have to investigate. It could be an infection. It could be bleeding from maybe a cervical polyp. It could be uterine fibroids. So really one needs to examine and determine the actual cause.
Okay. And related to the topic today, but someone is asking HPV vaccine for young girls was intended to minimize cancer for the cervix. Why why is it why what the target achieved and the cost is too high? Okay.
Yeah, the HPV vaccines are actually to prevent infection with the HPV virus, which causes cervical cancer, vulval cancer, and colorectal cancer. So the principle is if you give it early enough, that is to young girls from 10 years all the way to 26 years, that's the optimum age group, then you'll prevent them from getting this virus. And by prevention of this virus, then you prevent them from getting all these cancers, cancer of the cervix, colorectal, vulval cancer, which are fairly common now. And even throat cancer is associated with HPV. So the benefit is wide. The rationale of giving young ones is that you give them before they are exposed, because it's a sexually transmitted infection. And it is safe. In terms of cost, now the government is giving this vaccine to 10-year-old girls for free. We just walk into any government facility and the 10-year-old girl will get. Once this is acceptable to the population, then a free one will be rolled out to the rest of the population. Currently, the vaccines will go about 3,000 to 3,500 per dose, and one needs about 3 doses.
Thank you. Do we have centers using PPL suction curettes?
Using?
The endometrial PPL suction curettes?
Yeah, this we do in our clinics. It's done it's an office procedure, very easy procedure.
Okay. So you can just get the biopsy there and then in the office, huh?
Yeah, in the office, and the client goes home.
That's nice. It's a peculiar question, but somebody is asking, people who have painful menstruation, are they prone to having gynecological cancers?
No, because that tends to be some sort of hormonal imbalance. So this has not been shown to be associated with endometrial cancer. The only reason is a good number of them tend to have endometriosis, which is not cancerous. That's the condition where there's tissue, say in the peritoneal cavity on gut, could be in the lungs, which bleeds during the menstrual bleeding of the uterus. And this causes irritation and a lot of pain.
For the estrogen positive CA endometrium,
Yes.
Is tamoxifen routinely prescribed?
We tend to use the other agents like progesterones and letrozole. Yeah, they're much safer to use.
Is there a role for bevacizumab in CA endometrium?
Yeah, bevacizumab is these are the new types of chemotherapy. They are called targeted chemotherapy, and they are useful in almost all cancers. The only limitation is the cost. It has been found to be more useful in CA cervix and CA ovary. Yeah, but it will have a role for the patients who can afford.
How much is it?
I think at Kenyatta now it's about 93,000 per dose. So outside it's much more expensive.
Okay. I had a 31-year-old woman. Okay, sorry, I'm just going through the questions. I'll just pick them randomly. I had a 31-year-old woman with the Koitak age at 30 years and negative HPV DNA testing asking for HPV vaccination. Would you vaccinate?
Yes. Okay. So the vaccination, the optimum age is up to 26, but the others, so long as they don't have cancer of the cervix, there's still some benefit. It might not be as high as for the younger women, but they can still benefit. Yes.
Um,
This one who is asking, can one perform TH in the presence of abnormal bleeding if the facility that setting doesn't allow for establishing of a diagnosis? Actually, the answer should be no, because if you can do the surgery, then you can take the biopsy. You can do a DNC, you can do an endometrial pipelle. So there is no setting where you're able to do the surgery, but you cannot take the biopsy.
yeah. Now on polycystic, I think it's one of the ones somebody brought out. Polycystic ovarian symptoms be at risk of endometrial cancer.
Yes, it has a risk.
And how would you manage it?
Because with polycystic ovary, there are some hormonal, very high levels of the steroid hormones, so it should be managed as appropriate. Sometimes with myoinositol, it is managed with metformin, ovarian drilling. Yeah.
Someone is asking for elaborating on smoking. Is there a specific pathophysiology or physiological explanation? It's idiopathic. Nobody knows how smoking
It's
is
because
protective.
probably smoking, the chemicals cause endometrial atrophy. So they shrink the inner lining of the uterus for chronic smokers, and that reduces the risk. But take note, I said you can't use smoking as a preventive measure. It is just a by the way observation. Yeah, so people shouldn't take it too heavily.
It seems like almost 5-6 questions people are addressing about smoking. No, Dr. is not advocating for people to smoke. It's just something that was found out by probably
It was an observation.
an observation, not a recommendation to smoke. Are there studies to show that? I think that's a nutritional question. Well, I'm looking for more questions related. Maybe you can answer the 3 doses for vaccine. They're being given on a 3-month basis.
Oh, the vaccines for HPV are given at the initial one, then after 1 month, then after 5 months. So within six months.
Yeah. Is somebody asking for your contacts, Dr. Dr. Mukumba works in KNH. You can always find him in our COC or
Exactly.
Dr. Plaza, I believe Fortis. Yeah. So are there any studies to show? No. I think we've exhausted most of the questions.
Yeah, we have.
Maybe as a wrap, because we are done with most of the gynecological oncology session, what are apart now from endometrial cancer, the rest have a routine screening process.
Yeah.
CS cervix, you'd advocate for pap smear.
Yes, yeah.
And nowadays you can even get pap smear, you go to Lancet and do it yourself if you're not comfortable going to the doctor.
Self-kit.
The self-kit. For ovarian, we can do CA125. For choriocarcinoma, we can always beta HCG. And I believe those are the main ones, right? Yeah. So thank you very much, people, for listening. I believe we had addressed most of the questions on the panelists. Most of the questions asked on the Q&A. We'll have our next session today at 6:30. This is mainly for pharmacy people who are listening in to address the PPP CPD queries. It's only for 30 minutes because we've had too many questions regarding this issue, and Dr. Awak from the Hospital Association would be hosting and able to address those concerns. Our next session would also be on Thursday, today at 7 on immediately afterwards on the rollout of COVID vaccine. Today also, I forgot to say, I was hoping, it's just we're having too many activities, but I was hoping we have Dr. Etao to speak on rheumatological. It's World Young Rheumatological Day. So just to bring awareness to most of the people, rheumatology is there. It's actually affecting a huge population in Kenya. And maybe one day we'll get to speak about it. Thank you very much. Have a good day.
Thank you. It was good. Asante sana.